It is my very distinct pleasure to be able to introduce to you today our guest speaker, Dr. Arjun Srinivasan, MD, Captain, United States Public Health Service. Our guest is the Associate Director for Healthcare-Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at the CDC. Prior to heading to the CDC, he was Assistant Professor of Medicine in the Infectious Disease Division at the Johns Hopkins School of Medicine. We are so fortunate to have him with us today, and we are all very much aware of the great deal of activity that is going on around the concept of the process, the infection, Ebola itself, and all of the work that the CDC has actually done in this regard. This session on Ebola is intended to give you the current state-of-the-art knowledge and information that you can use at home, in your practices, and your hospitals. If you have not already done this, I would suggest that you access the AMA's Ebola Resource Center on the AMA homepage. It is updated regularly as we receive new information from the CDC, and it gives you an amazing array of sites of information and sources of learning around what should be going on around Ebola management. As physicians, we are accustomed to the evolving nature of medicine and the need to learn rapidly. Now is such a time. So please join me in welcoming our guest speaker.
Thank you so much, Dr. Hoven. I appreciate the opportunity to be with all of you today. I want to extend my thanks to the AMA House of Delegates for giving me the opportunity to speak today. And tell Dr. Hoven, you can tell whoever challenged you on the pronunciation of my last name was totally wrong. That was fantastic. It's my pleasure to be able to speak with you a little bit today on some brief background about the Ebola outbreak with a focus on how that information translates into the recommendations that we're making on the prevention of transmission of Ebola virus disease in the United States, particularly in our healthcare settings. As all of you know, Ebola is a disease which poses enormous challenges from the perspective of infection control and understanding how to prepare healthcare facilities to care for patients safely, to evaluate patients safely, is so important to what we need to do with responding to this outbreak. Those of us in public health at CDC, at the federal level and at the state and local levels, view our primary mission as being there to support all of you in the delivery of healthcare, to give you the information that you need to provide safe and effective care for your patients. And I hope that you'll view today as the beginning of a dialogue. The information, the questions, the comments that we get from our colleagues, our clinical colleagues, are so helpful in allowing us to provide information and to develop recommendations that are useful to all of you. Without question, we've learned that the care of patients with Ebola virus disease in U.S. hospitals and healthcare settings is enormously complex and very challenging. However, we have also learned that this can be done safely and effectively if we have strong quality and safety systems in place before we have to provide that care. We believe that there are 5 key pillars on which a good quality and safety system for the care of a patient with Ebola virus disease has to be built for our U.S. healthcare systems. The first is good leadership to provide the resources and support that are necessary for effective prevention precautions. The second is some person who's designated as an on-site Ebola site manager who can oversee both the development and implementation of the recommended precautions for caring for patients with Ebola. There need to be clear, standardized procedures. Facilities that will be seeing these patients need to have robust Ebola preparedness plans that are in place with very clear procedures for all people to follow. With respect to the personal protective equipment, there is no question that extensive practice is absolutely critical to making sure that we can put on and take off the equipment properly. And finally, we need to make sure that there's oversight of these practices, and particularly direct observation and oversight of the putting on and removing of personal protective equipment. Let me say a few words about the current outbreak. Though we're going to focus on the domestic aspects of Ebola management, we can't have a discussion about Ebola without spending just a couple of minutes to talk about what's going on in West Africa, an absolutely unprecedented outbreak of Ebola virus disease, many orders of magnitude larger than any other Ebola outbreak that we've ever experienced. More than 13,000 cases as of last Friday, with 4,950 confirmed deaths. It's been estimated that without interventions, by the middle of January, there could be somewhere between 500,000 and close to 1.5 million cases of Ebola virus disease in West Africa. We know that aggressive interventions to control Ebola in West Africa will be critical and fundamental to saving thousands and hopefully tens of thousands of lives of people there in West Africa. And just as important, we have to note that efforts to control the outbreak in Africa are the most effective strategy to controlling and protecting the rest of the world. We cannot be completely safe from Ebola in this country or in any country until we can get control of the outbreak in Africa. Here in the United States, as most of you know, there have been a handful of cases. A few patients have been evacuated, who've been diagnosed in West Africa, have been flown to the United States to receive care at a number of different locations around the country, Emory, Nebraska. And all of these patients, fortunately, have recovered and actually have been discharged from those hospitals. So I think that's a really wonderful statistic. We know that there have been 2 patients who have been in the endemic area who have had their Ebola virus disease diagnosed after returning to the United States. And we also know that, unfortunately, 2 nurses who cared for one of the patients, actually right here in Dallas, were diagnosed with Ebola virus disease. And fortunately, as well, both of those nurses have made full recoveries and have gone back to their normal lives. From the CDC's perspective, our response to Ebola has actually been very active for a long period of time. We activated our Emergency Operations Center to respond to the crisis way back in July, when it really became a large issue in Africa. We currently have more than 250 of our CDC staff who are deployed around the world, a lot of them in West Africa, but in other countries in the region as well. We have staff that have deployed to a number of different states. We have more than 1,500 staff who are working in Atlanta, who've been activated to respond to this outbreak in Atlanta and the States. And we've responded to more than 30,000 calls from a variety of the public, clinical partners. So there's obviously been a tremendous amount of interest, a desire for information, and CDC is obviously committing huge resources to try to meet that need and provide people the information and recommendations that they need. Let me say a few words about Ebola itself and on the transmission data that we have for Ebola virus. As most of you know, Ebola is one of the prototype viral hemorrhagic fever pathogens. It's a non-segmented negative strand RNA virus. It's an enveloped virus, which means it falls into the category of the viruses that happen to be the easiest to kill and the least able to survive environmental drying and persistence in the environment. Causes severe disease with very high case fatality, as I'll show you, and of course there's no specific treatment or vaccine. There have been a very large number of previous outbreaks of both Ebola and Marburg, a very closely related viral hemorrhagic fever virus, since 1970, since Ebola virus was discovered in 1976. The 2014 West Africa outbreak is caused by one of the 5 known subtypes of Ebola virus, the Zaire Ebola virus. We know that Ebola virus is primarily a zoonotic disease. We don't know the exact zoonotic hosts. We believe that it is bats, but we don't know exactly which species of bat is the vector for Ebola. Human outbreaks of Ebola virus generally occur when humans come into contact with the vector. A human is infected with Ebola, and then there's rapid spread, usually, of human-to-human disease until the outbreak can be brought under control. Generally, the outbreaks in the past have been brought under control relatively quickly. What's unprecedented about this outbreak is, of course, the scale of the disease. With respect to transmission, we know that the virus is present in very high quantities in a number of different body fluids and in blood, and this is what poses the very high risk of transmission. There are a number of different opportunities for human-to-human transmission to occur. From direct contact with either broken skin or mucous membranes with fluids that contain the virus. Sharp injuries have been reported. There's been disease transmission through needle sticks. Direct contact with the corpse of people who have died from Ebola virus disease. The corpses of people who have died from Ebola are known to be highly infectious. And there are rare reports of indirect contact, of fomite transmission, where a person has come into contact with a contaminated item. But I will mention that those reports are very, very unusual and constitute the vast minority of reported routes of transmission. The overwhelming majority of transmission of Ebola virus occurs from direct contact of patients with contaminated blood or body fluids. From the animal perspective, there are very limited reports of animal transmission through infection, usually through consuming the meat of infected animals, which has been reported in Africa. I think it's helpful to understand the presence of Ebola virus in various body fluids, because I think that gives us a good sense of how we can combat transmission and helps us understand the transmission dynamics. This is data that's been compiled from a few different sources, which shows when Ebola virus is detectable in different types of either blood or body fluids throughout the course of illness. And one of the things that I think this slide emphasizes is the large number of body fluids that do contain Ebola virus during the course of clinical illness. You can see that nearly every type of secretion has Ebola virus in it at some point during a patient's course of illness, and that includes even sweat, so it can get onto the skin through the sweat. Obviously, the gastrointestinal secretions, either vomit or diarrhea, can contain very high levels of Ebola virus during the course of clinical illness, and it's been those types of secretions that have been the route of a great deal of spread because these patients are known to have very large volume watery diarrhea and a lot of gastrointestinal distress with vomiting, including projectile vomiting, that's been described. Just to give you a sense of how much virus can be detected, this is data that comes from levels of Ebola virus in serum. And as you can see, we're talking about millions up to billions of copies, or at least hundreds of millions of copies per milliliter of serum. And these levels have been reported to be fairly similar in diarrhea and in emesis. So this is a very, very high level of virus that's present in blood and body fluids. And obviously, this is one of the reasons why these materials are so highly infectious. You can see that patients who die of Ebola virus tend to have much higher levels of viremia than patients who are able to survive the infections. So let me present some of the data on human-to-human transmission, because I think this data is so important to our understanding of how to prevent the transmission of Ebola virus disease in U.S. healthcare settings. We know that infected persons are not contagious until the onset of symptoms, and that's been demonstrated, I think, pretty consistently and strongly in past African outbreaks, and I think some of the data in this country also has suggested that same finding. The infectiousness of body fluids increases as a person becomes more ill, as they progress into the into the phase of the illness where they have very high levels of viremia and a large number of clinical manifestations. We know that human-to-human transmission has not been reported from aerosols, but we do know that transmission from deceased persons has been consistently reported, and that the corpses, I've mentioned, the bodies of patients who have died from Ebola are very infectious. I'll present a few studies on data from household transmissions because I think I found these studies to be quite helpful in understanding the transmission of Ebola. And all of these studies are really nicely summarized in an Ebola transmission brief that's currently available on the CDC website. Some data from household transmission. A good study comes from a 1995 outbreak in Kikwit in the Democratic Republic of the Congo. What's interesting to note about that outbreak is that there were 28 cases that arose from the 28 contacts in cases of the 27 primary patients. All 28 of these patients, the contacts who developed Ebola virus disease, reported direct physical contact with a known patient. There have been other studies that have shown similar findings, that all of the cases arose in household members who had direct physical contact with the patient. So a very large number, 150 or so folks, who lived in the same houses as these patients, shared airspace, shared that confined space, did not develop Ebola virus disease. It was only the household members who had direct contact who subsequently became infected. What do we know about transmission to healthcare personnel? We know that there are tremendously high risks here. Most of these outbreaks, the healthcare personnel have been a large percentage of the patients who have been infected, and that has also been the case in the current outbreak in West Africa. We know that the risk of infectiousness is higher when people have late-stage illness with very high viral loads and severe gastrointestinal symptoms. There is limited experience that invasive procedures can increase the risk. For example, blood draws have been found to be associated with disease in healthcare personnel, perhaps from needle sticks. There's no data present on any risks during aerosol-generating procedures, predominantly because these procedures generally aren't done in most of the places where these outbreaks have occurred. What we do know from our experience in managing these outbreaks in Africa is that the implementation of infection control precautions has been very, very effective in protecting healthcare personnel from the transmission of Ebola virus disease. Two good examples of that. The first comes from that 1995 Kikwit outbreak that I was mentioning before. Before infection control precautions were implemented, before they knew what was going on, there were 80 cases of healthcare personnel who contracted Ebola. Following the implementation of recommended infection control precautions, there was only one subsequent case, and it was in a nurse who reported inadvertently rubbing her eyes with soiled gloves. So a very well-recognized exposure there. So went from 80 cases of transmission to basically zero following the introduction of precautions. An outbreak in 2007, 2008 in Uganda, there were 14 healthcare personnel who contracted Ebola virus disease before the implementation of precautions, and none of them, there were no healthcare personnel who contracted Ebola following the implementation of precautions. So I think a good proven track record in Africa, in outbreaks in Africa, demonstrating that infection control precautions are highly effective at preventing the spread, the transmission of Ebola. Airborne transmission has been something that has been talked about. It has not been demonstrated in humans. There's currently no evidence of airborne transmission in either hospitals or home settings in past Ebola outbreaks, and that includes data demonstrating that people who have shared airspace with patients with Ebola have consistently not become infected. And in the Kikwit study, they did a case control study and found that the presence of cough in a case patient did not predict the transmission of Ebola virus. So I think further evidence against aerosol transmission of Ebola. It's important to understand whether or not this outbreak in West Africa of the Zaire Ebola virus is consistent with past outbreaks of Ebola. I think a knowledge that this outbreak is consistent helps us feel much more confident in the infection control recommendations that we might make. And what we have found so far is that this outbreak has been highly consistent with what we know about Ebola virus, about how this virus behaves. The incubation period, the duration of illness, the case fatality rate are all very consistent with what's been described in past outbreaks. And the reproductive number, the R0 of this outbreak, is again very similar to past outbreaks of Zaire Ebola virus. The reproductive number that's been reported in the various countries is anywhere from about 1.4 to about 1.8. So this virus appears to behave very similar to the other types of Ebola virus that we have encountered before, which makes us confident that the transmission mechanisms are the same that we would have seen in past outbreaks. I'll say a few words about the clinical findings and lab findings of patients who develop Ebola virus disease. There's generally an acute onset of symptoms with Ebola virus. Generally, this occurs between 8 and 10 days after exposure. Onset of symptoms has been reported as quickly as 2 days after exposure, and clinically, the latest onset that's been reported has been 21 days after exposure. The initial signs and symptoms are nonspecific. They're what I think we would all describe as flu-like symptoms: fever, chills, malaise, myalgias. The gastrointestinal symptoms tend to start after about 5 days with diarrhea and vomiting. And what we've heard from the clinical experience in this country is that those symptoms can be very severe. Bruce Ribner, the lead clinician at Emory University, gave a talk at the infectious disease meeting and mentioned that some of those patients has had 5 to 10 liters of output per day of emesis and diarrhea. So tremendous output of very highly infectious patient waste. Ebola is called a hemorrhagic fever. It may be a bit of a misnomer in that only about 20% of patients develop the hemorrhagic complications that many of us think about when we hear the word hemorrhagic fever. The challenge, of course, with diagnosis in these cases is that there are so many other potential causes of these types of very nonspecific symptoms in patients who are resident in these African areas, and malaria and typhoid fever, of course, being chief among those. This is a nice compilation of some of the clinical manifestations by the various organ systems that have been reported from the current West Africa Ebola outbreak. You can see that the overwhelming majority of patients do have fever. A large number have headaches. The gastrointestinal symptoms are very common, present in about 2/3 of patients with vomiting and/or diarrhea. Bleeding has been reported in about 18%, so very consistent with past outbreaks of Ebola. Laboratory findings, these are, I think, largely what many of us would expect for a viral illness, particularly a severe viral infection. Patients often have low platelets, so thrombocytopenia that's been described in the 50 to 100,000 range. Early in the course of illness, there's often leukopenia, which is later followed by leukocytosis and neutrophilia. Elevation of liver enzymes, usually AST, a little bit more than ALT. Significant electrolyte abnormalities, and this is again something that Dr. Ribner emphasized in his talk, tremendous derangements in a large number of electrolytes, and this has been one of the areas that he feels that they've really made strides in, is working to aggressively manage those electrolyte abnormalities. There can be coagulation abnormalities, and there can be significant renal abnormalities as well. We have good diagnostics for Ebola virus. The workhorse diagnostic tool for the diagnosis and the management of patients is the real-time PCR. It can be very accurately used to diagnose acute infections. It's more sensitive than the past antigen detection tests that have been used. There are a couple of different genetic fragments that serve as the targets for the real-time PCRs, and different labs are able to use different targets to either detect or confirm infection. The testing for Ebola virus disease, the PCR, is present in a number of the reference lab, the laboratory response network around the country, and of course confirmatory testing is available at the CDC. It's important to note that a negative test greater than 3 days from the onset of symptoms is highly predictive of the absence of Ebola. So a negative test more than 3 days from symptom onset means that Ebola infection is very unlikely. However, the test takes about 3 days to become positive. The viremia levels can sometimes take up to 3 days to reach the limit of detection in a patient who develops viremia. So if you have a person who you suspect might have Ebola, but is within the first 3 days of symptoms and the test is negative, the recommendation is to retest 72 or more hours after the onset of symptoms before declaring that the person does not have Ebola. The real-time PCR is the most of the testing that's being done, but it is important to note that there are other types of tests that can be done, but that are primarily useful, I think, from the research perspective and in better trying to characterize the disease. Virus isolation is possible, but can only be done in a biosafety level 4 laboratory, so a very small number of those laboratories around the country. There are histopathology and immunohistochemical stains that can be used on tissues, and of course, there are ELISA tests for the antibody response, both IgM and IgG antibodies. And these antibody tests have been very useful in helping characterize the course of illness and helping us understand the immune response to Ebola. Taking all these tests together, we're able to construct a chart of the expected diagnostic findings, the test results, in a course of illness of Ebola virus. You can see that the real-time PCR is the first test that becomes positive, somewhere in that 3-day range from the onset of fever and the onset of viremia. The IgM levels tend to come up within that first week or so of illness and become detectable soon after that. And then there's an IgG response that becomes positive, detectable, onset around 10 days, and then quickly becomes detectable. The IgM and IgG responses do tend to persist for many, many years following exposures, particularly the IgG response, which can last for years. The IgM response lasts for a few months, and the IgG response lasts for many years following exposure. With respect to the clinical course, we know that the nonspecific, the flu-like findings can progress to hypovolemic shock, multisystem organ failure, can progress to hemorrhagic disease and death. We know that the case fatality rate of the current outbreak in West Africa has been about 70% among the cases that have been diagnosed and managed in Africa. What we are learning with our very limited experience in this country is that intensive care, especially the intravenous fluid and aggressive electrolyte management, appears to play a strong role in increasing the survival rate of patients who have Ebola virus disease. Patients who survive often have clinical signs of improvement by the second week of illness. 6 to 11 days has been termed that magic number of where patients who are going to survive will generally appear to be responding to the illness. It is associated with the development of the virus-specific antibodies. And as I mentioned, the neutralizing antibodies, IgG neutralizing antibodies, have been reported detectable up to 12 years after infection. A number of patients have had prolonged convalescence with very long convalescent symptoms, arthralgias, myalgias that can persist for very long periods of time. The clinical management of Ebola virus disease has been an area where we are gaining knowledge with the experience of the care of patients in this country. It's been described as being supportive but very aggressive. So hypovolemia and sepsis physiology requires, of course, aggressive fluid resuscitation, hemodynamic support, very aggressive management of electrolyte disturbances and acid-base abnormalities. Dr. Ribner has mentioned the need to really stay on top of the electrolyte abnormalities. They can be very, very quickly evolving. Symptomatic management of fever and gastrointestinal symptoms with the admonition to avoid nonsteroidals that would increase the potential risk of bleeding. And it's been noted that multisystem organ failure can develop. Oxygenation requiring mechanical ventilation has been described in this country, and renal replacement therapy has also been described. There are no approved Ebola virus specific therapies, either for treatment or for vaccines. Ribavirin, the antiviral that we often turn to, does not have in vitro or in vivo activity against Ebola. As many of you have probably heard, there are a number of therapeutics that are in development with very, very limited human data. There's a convalescent serum that's been used in a small number of cases, and then a number of the therapeutic medications, ZMac, Tecmira, and the brincidofovir, that have also been tried in a very small number of cases. There are vaccines that are in clinical development. Many of you might have seen the news that I believe the NIH will begin early trials of an Ebola virus vaccine. I believe it's in the coming week. These vaccines are certainly exciting, and we want to see development of these, but they are not currently ready for use. So taking all of that information about the clinical syndrome of Ebola and what we know about transmission, we are able to make infection control recommendations for Ebola virus disease in the United States. And the cornerstone of infection control recommendations in all healthcare settings, be they in this country or in Africa, has to begin with early identification. The early identification of potential case patients, which can lead to immediate isolation, is the best way to implement infection control strategies and protect patients and healthcare personnel. There's the need to screen for exposure risk. There are two items that have to be fulfilled, two criteria, in order to have a risk for Ebola virus disease. There needs to be some exposure, so contact in the past 21 days with either a confirmed patient or a suspect patient, or residents or travel to an endemic area. In parallel with the exposure symptoms, you have to have clinical symptoms. There has to be a fever or any of the other Ebola-compatible symptoms. Those are the two criteria. Those are the screening questions that we need to have in place throughout the healthcare system in order to make sure that we're identifying patients at the earliest possible moment, the exposure risk in combination with symptoms. As many of you know, the United States has implemented a very aggressive policy for entry screening and education of people who are returning from West Africa. People who are traveling from these endemic areas are being evaluated and educated on the signs and symptoms of Ebola on their arrival to the United States. And they're being given detailed instructions along with the thermometer so they can check their temperature. They're being instructed to touch base with their state or local health department immediately upon arrival to their final destination. And then the health departments are then assuming the responsibility for monitoring of these patients, either through what we call direct active monitoring or active monitoring of all return travelers for 21 days. This type of monitoring also applies to healthcare personnel who are providing care for patients with Ebola in our U.S. hospitals. There are two types of monitoring that are being recommended. There's direct active monitoring, and this refers, as its name would imply, to a public health official directly observing the patient on a daily basis, at least once a day, to assess them in person for symptoms and to witness the taking of the temperature. The other type of monitoring is active monitoring. This is that the individual will self-monitor for fever and other symptoms, and then will report back to the health department to let them know on a daily basis what their temperature is and if they have any symptoms. And the level of monitoring depends on the exposure risks. So for healthcare personnel, there are basically three levels of exposure risk that have been identified: high, some, and low risk. High risk refers to situations where there's a known exposure. There's a breach, a failure of the personal protective equipment so that we know that the healthcare worker has been directly exposed to Ebola virus. High risk also refers to healthcare personnel who are working in a facility, who are in the Ebola area of a facility where there is transmission of unknown source. That is, when you have healthcare workers where we don't know that there was a breach in the protective equipment and we don't know how the virus is being transmitted, healthcare workers, personnel in that area would be considered to be at high risk because we simply don't know the epidemiology of what's going on. Healthcare personnel who have patient contact in an endemic area while they're wearing protective equipment and there's no breach in that equipment are considered to be at some risk for disease. The reason for a differentiation between providing care in an endemic area and in the United States is, of course, the presence of the disease outside of the healthcare setting in an endemic area. So healthcare personnel who are in U.S. hospitals where there is no endemic transmission of Ebola virus disease, who are caring for a patient who has Ebola virus disease in a hospital, if there are no breaches in protective equipment, those healthcare personnel are considered to be low-risk exposures. So taking all of those exposure risks together, you can see the recommendations for both the monitoring and for public activities for persons who are potentially exposed to Ebola virus disease. And let me summarize what these are for healthcare personnel. Healthcare personnel in the United States who are providing care to patients who don't have breaches in PPE are in that low-risk category. If they are asymptomatic, they can provide care as usual. That means they can continue to see other patients. They do have to undergo direct active monitoring, but there are no restrictions on travel or other activities. In a situation where a healthcare personnel is caring for patients where there is transmission of an unknown source or a failure, a breach of personal protective equipment, those healthcare personnel would be in the high-risk category. They should not care for other patients, and there would be appropriate restrictions then on travel and movement in public locations. We have developed infection control guidance for evaluation and management of patients with known or potential Ebola virus disease, and we have different recommendations for different healthcare settings. And what I'd like to do is go through each of those recommendations with you now. I'll begin with the ambulatory non-emergency department setting. We do believe that patients generally should not be evaluated for potential Ebola virus disease in this setting. Most of these clinics are not equipped with the right types of personal protective equipment to protect the healthcare personnel and are oftentimes not equipped with the types of resources that would be needed to perform an evaluation of a patient who might have Ebola virus disease. We do think that telephone screening can help ensure that symptomatic patients with exposure risks do not unexpectedly come to these settings. So at the time that appointments are being made or confirmed, the screening questions could be asked to make sure that you're not dealing with a person who you don't know has symptoms and exposure to Ebola. I do believe that the chances of an unexpected arrival of a patient who has both an exposure and symptoms are greatly reduced because all of these patients are now under active monitoring from public health authorities. So we will know when these patients develop symptoms at the first moment that they develop symptoms, and those patients can then be directed to an appropriate location to receive care. So I think the chances that we will be encountering these patients unexpectedly in ambulatory settings is very low. Nonetheless, we do have to have plans in place to account for what would happen if a person were to arrive. We do want people to be doing aggressive screening, and that screening could also have to happen at points of entry to the clinic just to make sure if it was someone you couldn't reach on the phone before the clinic, or even redoing that screening when people come to the clinics. And I've seen lots of places that are implementing this in the intake of their clinics. If a person does come to your clinic, you have an unexpected arrival of a person who has an exposure risk and symptoms, what we recommend is that you immediately place the patient in a private room and that you immediately call the health department to arrange for the transfer of that patient to a facility where evaluation can be done. We recommend that you avoid direct contact with the patient. Most clinics, ambulatory settings, do not have the types of protective equipment, personal protective equipment, that would be necessary to interact with a patient who has Ebola. That's especially true if the patient is bleeding, vomiting, or has diarrhea. We do believe that that should precipitate an immediate call to EMS to get that patient into an appropriate area where they can receive care and can be cared for safely. If contact is required, the staff should protect their eyes, mouth, clothing, and hands using protective equipment that might be available, face shields or goggles, surgical mask, a gown, and at least 2 pairs of gloves. But again, we do believe that you should avoid direct patient contact in these settings given the limited access to appropriate protective equipment that's available. We have guidance for emergency medical services. Most emergency medical services in the country have incorporated the screening questions for Ebola into 911 calls so that they can be alert for and know when there is a risk of a pickup of a patient who might have Ebola virus disease. And when there is a potential patient, the EMS crews are deploying with personal protective equipment. Our recommendation is that they follow the PPE recommendations for the care of hospitalized patients, and I'll go through exactly what those are. We also have specific guidance for the emergency department, and we do believe that every emergency department probably does have to be prepared to provide some degree of initial evaluation and care for a patient with Ebola virus disease. We don't have complete control over where these patients might need to go if a medical emergency were to develop. And we know that several emergency departments around the country already have evaluated and cared for patients who might have or have Ebola virus disease. Again, point of entry screening is absolutely critical in the emergency department. I've seen, again, a number of emergency departments who have taken different approaches to that, but what appears to be very commonly done is signs at entry points, alerting patients and visitors to notify staff immediately if they have any sort of travel or exposure risks, and also triage questions, so both passive and active questioning, triage questioning at the very first interaction with patients as they enter the emergency department. If you have a patient who has exposure risks and symptoms, we recommend that you activate an emergency department Ebola management plan, that you immediately activate the plan that's in place to evaluate that person safely and carefully. The patient should immediately be placed into a private room, ideally with a bathroom or at least a portable commode. Immediate notification of both the health department and your facility's infection control, and then implementation of the recommended personal protective equipment as you begin the evaluation and care of that patient. The Emergency Department Ebola Management Plan, this is very similar to what we recommend for a hospital management plan, but there are a number of issues that need to be addressed. These are very complex issues and require quite a bit of thought before you can safely evaluate these patients. You need to have someone on site who can oversee preparedness, making sure that the plan is developed and implemented effectively. We think you need to have a plan for patient placement. Where will you put that room? You do need a separate space, a private room where you can put that patient. And you also then need some designated area where your healthcare personnel can both put on and take off the protective equipment that they need to wear to enter the room. You need to plan to have a very, very limited number of staff who are going to provide care. This is a situation where you want to do everything you can to limit the number of people who are going to be entering that room. There need to be advanced plans for training that very limited cadre of healthcare workers on how they can safely put on and take off their protective equipment. You will need to have supplies necessary. You do need a limited number of supplies for training for your healthcare personnel. And again, we think this is a limited number of supplies for the very small number of people who need to be trained and who would be providing the care for patients with Ebola virus disease or who need to be evaluated for Ebola virus disease. The lab has to be brought into the picture. There need to be plans for how you would run laboratory tests on these patients. And then there needs to be a plan for environmental cleaning and also for waste management. And these issues with lab testing, environmental cleaning, waste management are a little bit different from what we recommend as part of routine patient care. And so there are issues and considerations that need to be specifically thought through for Ebola. With respect to personal protective equipment, we recommend two different options for the care of patients who are in the emergency department who are being evaluated for possible Ebola. We recommend that there's one type of protective equipment that is an option to use in a patient who is stable, who's not bleeding, has no vomiting or diarrhea. So these would generally be patients who are very early on in the course of illness. For those patients, we do believe that safe care can be provided with a face shield and a surgical mask, so protection of the eyes, protection of the mouth and nose, the mucous membranes, an impermeable gown, and 2 pairs of gloves. If the patient is not stable, is bleeding, has vomiting or diarrhea, then in the emergency department, we do recommend that you follow the guidance for personal protective equipment that we recommend for hospitalized patients with known Ebola virus disease, and I'll go through those recommendations shortly. With respect to the lab, our recommendation is that clinical labs can safely handle specimens from patients who are under investigation for Ebola. There is specific guidance that's available for laboratories in the management of patients who are under investigation for Ebola virus disease. We do believe that lab staff who are handling these specimens should wear recommended protective equipment, and we do have recommendations for what those are, and that they use biosafety cabinets or splash guards to minimize the risk of exposure. Samples can be run on routine lab equipment, and we recommend that you follow the manufacturer recommendations for the safety features and decontamination protocols that would be used for other types of enveloped viruses, such as human immunodeficiency virus, or HIV. I think it's critically important to remember that of roughly 400 or so patients in the U.S. who have been evaluated for possible Ebola virus disease, only 1 case has been confirmed in an emergency department. So most of the patients who present for evaluation for Ebola, in fact, do not have Ebola. They have something else. And if Ebola is ruled out, all aspects of that patient's care, including the lab testing, environmental cleaning, waste management, can proceed per normal hospital protocols. So what about the management of patients with confirmed disease in U.S. hospitals? Well, one of the lessons that we've learned and our experience in the U.S. suggests that the care of patients with confirmed Ebola virus disease is best carried out in hospitals that are well prepared, well equipped, and well supplied to provide this care. And we don't think that this is every hospital in the country, but a select group of hospitals. As many of you know, there are currently ongoing plans in collaboration between federal partners, state and local partners, and hospitals, healthcare systems, individual hospitals, to identify a small number of hospitals around the country where Ebola care can be safely and effectively delivered. And it will allow us to focus training and support resources towards those hospitals. And these are discussions that are ongoing now in a number of areas around the country. CDC, the Office of the Assistant Secretary for Preparedness and Response, and state and local health departments are working collaboratively with these hospitals who are interested in providing the full course of care for a patient with Ebola virus disease. We are sending teams to collaborate with the hospitals to help them prepare, to share lessons learned from other hospitals, to understand the barriers that they're encountering in their preparations, and to talk through potential solutions. We also have committed to collaborating with state and local health departments to send a rapid response team to assist any hospital in the United States where a patient is admitted to help them provide that care, to provide whatever assistance we can in helping care for those patients safely and effectively. We know that the safe and effective care for a patient hospitalized with Ebola is enormously complex and requires extensive advanced planning and training. And we have certainly learned just how complex this care is as we have begun to do this in this country. The good news is that there is experience with doing this safely and effectively in the United States, and we can learn from that experience to understand how to do that. Much like for the emergency department, there are a number of key considerations for the development of an Ebola management plan for a hospital that is going to provide the full course of care. And these issues are identical to the ones that I outlined in the emergency department. A facility manager, a careful plan for the placement of the patient that allows for careful space to both put on and take off protective equipment, a identification of a limited number of staff who would provide the care, training of those staff on how to put on and safely take off protective equipment, plans for necessary supplies, especially protective equipment, plans for lab testing, environmental cleaning, and waste management. The personal protective equipment for the management of a patient who is hospitalized with confirmed Ebola virus disease is extensive. It's built on the premise that there should be no skin that's exposed during the provision of that care. Many of you know that the CDC revised our guidance for protective equipment used in the care of patients with Ebola virus disease. And these recommendations have been developed in consultation and with input from all of the clinical centers in the United States who have firsthand experience caring for patients with Ebola virus disease. We did get input from folks at Emory, Nebraska, the National Institutes of Health, and this guidance, this revised guidance, reflects their input and their expertise. You can see the protective equipment that's recommended here. It's a single-use disposable face shield in combination with a surgical hood to protect the head that goes down to the shoulders, and face protection with an N95 respirator or a powered air purifying respirator that has a full face shield. A single-use disposable impermeable gown that extends to the mid-calf or a coverall, 2 pairs of gloves with extended cuffs that go up onto the gown, a single-use apron that we recommend when the patients do have extensive or do have diarrhea or vomiting, and then impermeable boot covers to protect the footwear. It's important to note that this is obviously protective equipment that most of us are not accustomed to using, especially for this hospital-type protective equipment. And it's important to note that putting it on properly and taking it off properly are incredibly challenging. The removal of protective equipment is a high-risk procedure. There's opportunity for exposure to potentially contaminated materials, and it's something that has to be done with enormous care and precision. In order to accomplish this safety, staff need extensive training and a lot of practice. They need to practice doing it. They need to be observed so that they feel confident and the facility feels confident that everybody entering that room knows how to put the equipment on and knows how to take it off. We recommend that every time personal protective equipment is being put on or removed, that be observed by a designated individual who has the pure responsibility of observing the putting on and removing of protective equipment, someone who's knowledgeable about personal protective equipment and can help the healthcare worker do these procedures carefully. We do have guidance on how to do this. The personal protective equipment guidance does have a step-by-step procedure for putting on and removing both of the options that we recommend, either the N95 respirator option or the powered air purifying respirator or PAPR option. And there have been a number of videos that have been developed showing healthcare personnel putting on and removing the protective equipment. And I point these out to you as excellent training resources. But I do point out that there is absolutely no substitute for hands-on practice. People have to practice with this protective equipment. And I'll also point out that these videos are guides. You may have differences in how you do this. We've heard from a lot of different hospitals who are using variations on what's outlined in the video, and that's absolutely fine. The key is to have procedures that work for your protective equipment in your hospital for your healthcare personnel. So the videos are training guides, they're suggestions for one safe way to do this, but there are certainly others out there, and the key is to develop procedures that your providers are most comfortable with, and then to practice on those procedures. I will mention that there is a recommendation for a respirator. I want to say a few words about why that recommendation is being made. It is not because we think Ebola is transmitted via an airborne route. There is no evidence that Ebola is transmitted via that airborne route. However, experience with caring for patients with Ebola virus disease in U.S. healthcare facilities indicates that patients might require an escalation in the level of care, including the potential performance of an aerosol-generating procedure, and that these procedures might have to be done unexpectedly. We know that putting on and taking off the protective equipment for caring for patients with Ebola is very time-consuming. It can take 8 to 10 minutes to put it on and 10 to 12 minutes or even 15 minutes to take it off. We don't want healthcare personnel to be in a situation where they're in a room and an aerosol-generating procedure has to be done, and we don't want them to be in a position where they have to rush to either take off the equipment to change the type of protection that they have, or to rush into the room with putting on respiratory equipment. We want them to be prepared to do whatever they would have to do the moment that they enter the room, and that's why there is a recommendation for respiratory protection. We have two different options that are recommended, either a fit-tested, NIOSH-certified disposable N95 respirator or a powered air purifying respirator. It's important to note that both have been used to safely care for patients with Ebola virus disease in the United States. The University of Nebraska uses the N95 respirators. Emory University and the NIH have been using the powered air purifying respirators. It's also important to note that the disposable N95 respirators and PAPRs have both been used for decades to safely provide care for patients with diseases that are transmitted by an airborne route, including tuberculosis. And that includes during aerosol-generating procedures. So both of these options, there's extensive experience in caring for patients with airborne diseases, and so we think both of these provide a high level of respiratory protection. There are some critical lessons that have been shared with us from the folks who have been providing this care about personal protective equipment, and want to share what some of these are. Again, this issue of a trained observer, someone who's watching every step of a person putting on or removing protective equipment, has been emphasized over and over again as being absolutely fundamentally important. What's been noted is that sometimes it can also be necessary to have an assistant there to help with certain steps of removing the protective equipment, especially if you're using the powered air purifying respirator. That can be a little bit tricky to remove carefully. We don't think that the observer should serve as the assistant. We believe, and what's been suggested from people who have been doing this, is that the observer's only job should be to observe. So if the healthcare worker needs help getting the equipment off, there needs to be another person who can assist with that, so the observer can only observe. It's important to inspect and actually decontaminate protective equipment before you take it off. And again, this is something very different from what we've ever recommended before, whereas normally we would recommend that you take off protective equipment even if it's soiled and simply throw it away. When you're caring for patients with Ebola, we recommend that you inspect the equipment, and if there is visible contamination of the gown, of the arms, of your gloves, that you decontaminate that equipment during the removal procedure, either using an alcohol-based hand rub or using an EPA-approved disinfectant wipe. The thought is that disinfecting the protective equipment before you remove it, again, reduces the risk of contamination during the removal process. You'll see in the recommendations that there are frequent steps of hand hygiene throughout the removal process with alcohol-based hand rubs, again with the thought that the hands being the highest risk area of contamination and transmission, it's important to keep the gloved hands clean during the removal process. What we've also learned is that more personal protective equipment is not always better. There has been the temptation to add additional layers of protection, more layers of gloves, more gowns, more shoe covers, more boot covers, and what people have told us in their experience with that is that adding additional layers or extensively taping the protective equipment can actually make it more difficult to get the equipment off and can actually increase the potential risk of contamination. What about disinfection of the patient care area? Here we have, again, some slightly different recommendations from what we recommend normally. We do recommend that there be daily cleaning of high-touch surfaces in the immediate patient care area. The best example of that is bed rails. But we believe that that cleaning, that daily cleaning, should be done by the clinical care team, the folks who are entering the room anyway to provide care. The rationale for that recommendation is that it reduces the number of people who will be entering the room on a daily basis. Terminal cleaning, however, should be done by environmental services staff who do have the appropriate training and expertise in performing terminal cleaning of a patient care room. You will need environmental services staff who are trained on the same types of protective equipment that the healthcare personnel are wearing, because they will need to wear that same type of protective equipment to enter the room, and they also need the same type of training with putting on and removing that protective equipment. In terms of what works for disinfection, Ebola, as I mentioned, is an enveloped virus. It's the easiest of all the viruses to kill, and there are a number of products that are highly effective at killing Ebola virus. Important to note that alcohol-based hand rubs are highly effective against Ebola, so the use of alcohol hand rubs is very effective in killing the virus that might be on hands. And any EPA-registered disinfectant with a label claim against non-enveloped viruses is effective. We do recommend selecting agents that have label claims against non-enveloped viruses because that's one category above what's necessary. It provides a little bit of a cushion, a margin of safety, because the disinfectant is effective, is more potent than what would be necessary just to kill Ebola virus. The way you can know if a product has a label claim against a non-enveloped viruses would be looking for products that are effective against norovirus, which is a non-enveloped virus. Waste handling has proven to be one of the most challenging issues in the management of patients who have Ebola virus. There are a number of rules and regulation which govern the management of waste, and there are different levels of oversight. So packaging and transport of Ebola waste would be governed by federal rules by the Department of Transportation regulation, but disposal of that waste is governed by state and local laws. So it's important to be familiar with both of those laws. And there's a lot of this guidance that's available on the CDC website. We also recommend that you consult with whoever your waste hauler is. A number of the waste management companies have been wonderful resources in helping people understand what the rules and requirements are. It is important to note that Ebola waste that's been inactivated in some way, that's been autoclaved, that's been incinerated. This is no longer infectious waste. This is, and it's not infectious in any way, shape, or form. There's no question that the current Ebola epidemic poses enormous challenges around the world, both to the patients and the people living in these areas who are confronting this outbreak, and also to healthcare delivery systems around the world. As I emphasized at the beginning, ultimately, the best way to protect us in the United States is to work aggressively to stop the outbreak in Africa. Until the outbreak is controlled, U.S. healthcare facilities need to be aware of the relevant guidance and be prepared to play the role that they might need to play in the evaluation or management of patients with Ebola virus. I again emphasize that we at CDC are eager to partner with you, to collaborate with you. We're committed to bringing you the latest information that we have when we have it. As all of you know, this is a fast evolving situation, and we are continuously updating the information that's on the CDC website as it changes, cdc.gov/Ebola. It's a wealth of information. All of the information I've shown you here, the videos, is all there listed under resources for healthcare personnel. One more slide, I think. That's the last slide. Okay. So all of that information is available on the CDC website. So encourage all of you to visit that website regularly for updates and information. But I really am looking forward now to sitting and having some dialogue and some discussion with you. This is an evolving situation, and things are changing as we learn. Oftentimes we get really, really good comments, suggestions on ways to disseminate information, on revisions, updates to the guidance that come from all of you, from folks who are practicing. And so I look forward to hearing your thoughts, your comments, your questions. Again, want to thank you very much for giving me the opportunity to be with you today. Okay.
What a wonderful, comprehensive presentation. Obviously, Arjun's an amazing resource, and I think the data and information that we saw is just very, very helpful and very useful, and I think all of us appreciate his efforts. I've got people lining up everywhere. The first person I saw was at microphone 6. Now, I may not be as clever as the speakers, but I will try to do my best to be sure that everyone gets a chance to ask the question. So microphone number 6.
Michael Liu from Massachusetts. First, thank you for that very informative talk. I thought I was well steeped in the subject, but I learned a lot from your talk. I would like to ask whether there have been seroprevalence studies in Africa or studies here in the U.S. to see whether contacts such as Mr. Duncan's household contacts seroconverted without getting symptomatic Ebola, i.e., is there such a thing as asymptomatic infection?
That's a good question. I'm not aware of prevalent studies that are being done in Africa or in the United States. We can check into that and get back to you. It's a good question.
Thank you.
Microphone number 4.
Hi, Jim Felsen, West Virginia. I was just excellent presentation.
Thank you.
Great information. But I was curious because we keep saying the best thing is to contain it in West Africa, and I really have not heard a good explanation of what exactly the WHO and the strategy is. I mean, I've spent time in Sierra Leone, and I'm not sure if the idea is to get patients out of the infected home somewhere else, or exactly what the containment from a public health perspective to give IVs and that kind of care. I understand that, but that's not going to contain the thing. But public health, I don't understand. Having walked into little tiny narrow paths into these villages and probably with no communication or a day or two to find out someone has symptoms, exactly what are they planning to do to cut down the spread? I mean, are they, like I say, are they planning to get everybody into those hospitals and out of the homes so no one gets? I haven't heard a good explanation of it.
I know that's part of the strategy. I'm not privy to all of the details, all the discussions that have gone on with WHO and other health organizations. I know, as you're mentioning, getting people into treatment centers and out of homes has been one of the strategies, but I don't know all of the different strategies that are being employed right now.
I would jump in here and say countries are deploying manpower, healthcare workers, equipment to the endemic areas right now in the hopes of, in fact, being able to provide the kind of infrastructure that will, in fact, help these individuals and make it more appealing to controlling the disease state. I think more is to come on that. We will have to wait and see.
But I think your comments from being there in the endemic region certainly point to the enormous infrastructure challenges with dealing with this.
Number 2.
Dave Welsh from
You're on.
Dave Welsh from Indiana, General Surgeon and County Health Officer. 3 quick questions. 1, are your slides available?
Yes.
To share? 2, on your slide you mentioned with the stool up to 60 days, I believe. Is that only if it's still diarrhea? And 3, you mentioned about confirmatory tests to the CDC. Is there any special considerations in sending that confirmatory test to the CDC?
The slides absolutely are available to you. I think they can email them or
Yeah,
they'll be posted, so they're absolutely available. The testing is done in discussion and collaboration with state and local health departments, so that the symptoms, there's a list and there's a discussion that goes on there. And then your second question was the 16. Oh, the
stool, how, you mentioned it could be positive up to about 60 days, I think,
Right.
on your slide. And is that only if it's still in a diarrhea state? Or?
That's not my understanding. My understanding is that that's just people who've done PCRs on stool to see how long they could recover it from stool. So it may or may not be related to diarrhea. But obviously, when patients have diarrhea, that's where there's the high risk of spread because of the large volumes.
I very much appreciate your presentation. Thank you.
Thank you. Appreciate your questions.
Microphone number 2.
Corliss Farnham, Oswego, New York Family Practice. 2 questions. Number 1, since you say it's not aerosolized, but if a patient is infected coughs, are you saying it's not in the cough productive phlegm, or why isn't it able to be transmitted or become infective?
Yeah, so it's an excellent question. So when we say airborne transmission, we're talking about diseases like tuberculosis, where the particles, get suspended in air, can travel over great distances, get through ventilation systems. Clearly, if a person has it in their saliva and then coughs, and that saliva makes contact with the mucous membrane, that could transmit Ebola. But that would be efficiently protected using a surgical mask. That's droplet precaution, droplet transmission via direct contact. That's, again, that route of direct contact. So that's what we're referring to here. There's clearly that could happen. What's been interesting is that, if you look at those studies, at least that one study that was done, that people who have coughs are not more likely to spread than people who don't. So again, I think it points to that issue that it's the folks who have direct contact, who are close enough where the body fluids, the saliva, can get onto their mucous membranes, who are at risk, and not people who are standing several feet away.
And one last one, not to cast blame, but the 2 heroic nurses who contacted the disease, did they are able to identify just what went wrong?
We don't know exactly what happened with those nurses in Dallas. What we do know is that the guidance that we had previously didn't work effectively to stop transmission at that setting, as that was, of course, one of the reasons for changing the guidance.
Microphone number 3.
Thank you again for an informative presentation, and sorry for the volume. I have 2 quick questions. Can you comment on our knowledge of whether IgG presence post-convalescence confers some form of temporary protective immunity, given our experience in previous outbreaks in Africa? And then my other question, at the risk of sounding like an alarmist, can you comment on the CDC's position on the risk of sort of a mutation to cause this particular strain to become airborne, similar to the Reston subtype?
So the Reston subtype is not doesn't infect humans. Right now, the concern is not over the transmission of a mutation of this virus to become an airborne type of virus. The concern is, of course, with the transmission via the known mechanisms. There's no evidence to suggest that there's a risk of it mutating to become airborne. And I know there's been a lot of discussion and fear about that, but I think the focus really needs to remain on we know how this is transmitted, and we need to take effective steps to containing it and curtailing it. There does appear to be protective immunity in patients who have IgG response. It's not known if that immunity is completely limited to the subtype of one of the 5 subtypes they've been exposed to, or if there's a cross protection across types, but there does appear to be some degree of immunity.
Microphone number 6.
Thank you. Theodore Zanker from Connecticut. My question is related to the general anxiety in communities around the whole issue of patients going to local emergency departments, particularly in municipal areas. I know that they're trying to arrange for certain hospitals to receive the patients rather than other ones. But after the experience in Dallas, and it's not immediately available to necessarily get experts on the scene, how come the CDC hasn't recommended that if a doctor gets a call or an ER, that they don't develop a flying squad for the whole area where they ask the patient to stay at home and don't be frightened that people with moon suits will come to you. I mean, after all, what they really need initially is drawing bloods for lab studies and stuff, and starting IVs, which even skilled paramedics can do. And it saves the whole community anxiety thing about not going to the hospital and stirring it up with the newspapers and all.
There's a lot of discussion about how, what are the best ways to evaluate patients who need to be evaluated, and there's a lot of discussion that's going on, the types of things that you're talking about with state and local health departments to try and best determine, how can that be done safely, effectively, in a very limited, in a very thoughtful way. The direct monitoring obviously helps enormously with that, because you know at the first sign or symptom that a person needs to be evaluated, and then careful plans can be made to determine exactly how that should be done most effectively.
Microphone number 2.
Steve Epstein from Massachusetts. I'm an emergency physician. I work in a tertiary center that's actually an Ebola designated hospital for our state, as well as in a number of community hospitals. We're about to have flu season. We're going to have a lot of patients coming in with fever, nausea, vomiting. Those who are or have traveled recently to West Africa obviously are going to be quite concerned, as are we, and we'll be using a lot of protective equipment. So I'm wondering if you have, first off, any guidance in general about what we're going to do with flu season coming up. Also, a very specific one, in one of my community hospitals, our nurses actually are taping our gowns. Not the aprons, but the gowns, which have seams. They're just taking tape and taping over the seams to prevent any leakage. Is that considered sufficient for the PPE? Because that's what's happening out there in the field.
Yeah. So the first one, we are worried about that same issue with flu season coming up. I think, unfortunately, the only answer, it's not a bad answer, is encourage people to get flu shots. Obviously, people who are protected from flu will make it less likely that they'll show up and need to be evaluated. The issue of the gowns and what to do with the seams, we're working on some guidance on that, because there have been concerns about whether or not the seams are a potential vulnerability for the gowns. Different gowns have different standards. It's a fairly complex issue. Some of them have seams that meet the same standards of permeability. Other ones have seams that are different. And so we're working on some guidance to help people better understand the specifics of the various gown types and whether or not the seams are different from the gowns or the same as the gowns. It's a very complex issue that we know folks need more guidance on. I appreciate your comment.
Thank you.
Thank you.
Microphone number 4.
Thank you. Lou Diamond, Renal Physicians Association. I'm not going to ask you about dialysis because you've issued a report on that, but I could ask you, if I could, a difficult question about how you handle cardiac arrests or recommendations about cardiac arrest, and do you have recommended the patients execute a living will and or DNR orders?
Yeah, that's an excellent question. It's come up many times. I know the Institute of Medicine actually convened a panel to discuss these very, very challenging ethical issues in the management of patients with Ebola virus disease. CDC we don't have specific recommendations in that regard. We do, however, recommend that it's an issue that, the hospitals that are going to be caring for these patients need to discuss with their ethics committee and make some determinations about what they think is the right thing to do. It's a very, very difficult issue.
Thank you.
Number 5.
Hi, thank you for the excellent presentation. Question, I'm from New Jersey and a family doctor, but I have a question about the PPE and the supplies of the PPE. I know in our system we're developing lots of training, so we're utilizing lots of the PPE just for practicing of donning and doffing them. But then, we're encouraging everybody here at this meeting to start making sure that's happening in their communities. So I anticipate there's going to be kind of a run on the PPE nationally, and so are there provisions to make sure there's a supply that will be ready, and do you have guidance on how much of these pieces of equipment should be stocked in certain areas or in ambulatory sites, et cetera?
Yeah, so there is a lot of discussion on that. We've already heard from some places that are, having a tough time getting some of the things that they need. So a couple of issues that I think are relevant there. As you point out, you need limited supplies for training. A lot of the material that you use in training, you can reuse some of that when you're talking about just training for putting on and taking off. We're working on some guidance to try to better understand how much is needed. We're talking to some of the places that are doing some of this care to try to get a better understanding of how much you would need to care for a patient for a typical day or a few days, so that we can give people some guidance for the hospitals and emergency departments who might be doing this. There are a lot of resources that are being brought to bear and a lot of communication. I think it's really important to note that in terms of providing care for patients, we expect to have a very small number of patients in this country, so we should have plenty of protective equipment to provide the care. What's key is making sure that the protective equipment is in the hands of the folks who are most likely to be evaluating and treating those patients. So what we are encouraging hospitals to do is, where they're encountering, if they're encountering shortages, difficulties in getting equipment for their training purposes to have on hand, that they work regionally through the health department. There are regional groups that are set up all over the country to help deal with supplies of personal protective equipment. And what those regional authorities know, that if they can't resolve the supply issues regionally, there are federal resources as well, both from CDC and from the Assistant Secretary for Preparedness and Response, ASPR, have federal resources to help as well. So there are a number of plans that are being discussed and in place to help manage any potential shortages.
Thank you.
Number 2.
Richard Ellison from Ohio. My question has to do with patients' expectations of privacy, and do HIPAA regulations change? I read in the newspaper that the individual from Maine is potentially leaving the community.
To my knowledge, there's no alteration or change in HIPAA rules or regulations for patients who have Ebola virus disease. They should be managed and treated just like other patients in our healthcare system, with the same type of dignity and respect.
Number 4.
Chris Gribben, New Jersey. 2 quick questions. At least the first one's quick. I practice at a hospital that's been designated as an Ebola reception center, not the one that hosted the nurse from Maine. And the introduction that we've received, in addition to what you described here, described a rather lengthy showering process after doffing the PPE. Is that part of the CDC recommendation?
We recommend that shower facilities be provided, not as a decontamination measure. At the end of the doffing procedure, there shouldn't be any risk of contamination unless there's been a breach of the protective equipment. However, we've certainly heard from folks that working in this protective equipment for a prolonged period of time, it's very, very hot. It's extremely uncomfortable. So we do recommend the availability of a shower facility as a comfort measure, but not as a decontamination measure unless there's a breach of the equipment.
The other thing I just want to know is our governor in our neighboring state, which does have a patient being treated, has a policy on quarantine that seems to be an evolution. What's the reports from New York in terms of how healthcare workers who would fall under the CDC low risk category for no breaches of their PPE, how are they being considered with respect to the quarantines that have been proposed?
That's a good question. I don't know. As you said, some of it's been in evolution. I don't know what the current recommendation is for those healthcare workers who are caring for that patient.
Thank you.
Number 3.
I'd like to know what the most common cause of death might be, and if some of these fatalities could have been reduced had there been aggressive supportive care.
My understanding is that the most common cause of mortality has been the type of hypovolemic shock from dehydration, and yes, the understanding is that aggressive supportive care, electrolyte abnormality corrections, aggressive fluid resuscitation appears to be effective in reducing the mortality rate.
Number 2.
Yes, Weisbuck from Arizona. 30 years ago, I had the experience of trying to develop an early surveillance system in Sierra Leone. And of course, that failed and fell apart when the Civil War came. Is the Center for Disease Control, in conjunction with the World Health Organization, working with the African countries and with other countries around the world to build a surveillance system and a service delivery system across the continent, so that other diseases of this type. Ebola will be suppressed in Africa in West Africa. That'll happen. But it'll probably occur again. The bats are not going to go away. So there will be problems of this type, whether it's Ebola or other forms of diseases which we don't know, or types of variations on the HIV type of virus. Are we building surveillance systems and clinical service, primary clinical services delivery systems in Africa to make sure that something like this doesn't occur again? Had the surveillance system been available, we would have known about the first case in Sierra Leone or in Liberia 12 months ago, and we could have acted against it and prevented the spread. What is being done now to expand on this and to provide a continent with the kind of protection that hopefully we have in this country?
Yeah, no, I think you're absolutely right. The outbreak certainly points to the critical need for a robust public health and healthcare delivery infrastructure as an important mechanism, and you're right. Ebola, this outbreak wasn't the first. This won't be the last, and it won't be the last disease. My understanding is that there is a lot of discussion that's ongoing about the critical need to bolster infrastructure, public health and healthcare infrastructure, not just in these countries, but throughout Africa. And I know those are ongoing discussions with CDC, World Health Organization, and other organizations.
Good.
It's a critical need.
Microphone number 2.
Thank you so much for that really enlightening presentation. I'm Catherine Mosley, a pediatrician from Michigan, and as a pediatrician, I am hoping that these incidences are few and far between, but I fear that possibly one of them will be a child. And so I have 2 questions. In pediatrics, when we have a child in intensive care, we normally ask a family member to room in with them, and I'm wondering, is there any guidance about that? And I'm a little disturbed when I see how long the virus persists in urine and stool, so I'm wondering about clearing the post-Ebola child for daycare or school or whatever. Is there any guidance about that?
We don't have guidance as yet on this is a difficult issue, and we're talking with a number of pediatric experts to try and better understand what the right recommendations are in the pediatric setting. A lot of challenges there, and we're working on those. All of the ones that you raised, both the issue of the need oftentimes for a parent to be present with the child receiving care, and then the issue of potentially sending a patient back into the community. There is some experience there. We have sent adult patients back into the community, so I think there are some guidance and some protocols for how we could safely do that in a pediatric case as well.
But they don't need their diapers changed in daycare.
But right, the
Usually.
rules are often different, and so there are discussions that are going on to try and get those issues sorted out, or at least some degree of guidance on.
And that'll be posted on the website as soon as you have that,
I think
hope?
initially it'll be probably involve direct discussion and contact with if there is a first case in pediatrics. But right, we hope to have some guidance up on the web for some of these issues in pediatrics as well.
Thank you.
Thank you.
I think if you watch the website and also watch the AMA homepage, as we get information new on guidances and information, it is directly sent to you all so you can get to it quickly and easily. Microphone number 4.
Joe Fallon, New Jersey. I'm just curious about the 21-day isolation, because when The Economist published an Ebola issue, their graph seemed to indicate that there was risk over 21 days. How solid is that 21 days?
So what I can tell you is my understanding is that the clinical evidence indicates that there have not been cases developing more than 21 days after exposure. I understand the paper that you're referring to, it is a modeling paper. The clinical experience suggests a maximum incubation or maximum exposure period of 21 days.
Thank you.
Thank you.
Microphone number 5.
Thank you for a very informative presentation. I noted in the monitoring of gowning, ungowning, treatment, that there's no mention of video recording of it, and I was wondering if that's been considered.
We have it as a suggestion for facilities that have that resource. I think it's a wonderful idea. I've talked to a hospital that's doing a lot of video monitoring. I think it's a great idea for places who have that facility, and they were able to retrofit it. They didn't have it initially and were able to set it up for this. I think it's a great idea.
Microphone number 2.
Hi, Donna Bloodworth, Houston, Texas. 2 questions. The first is, it seems like the face shield and particularly the respirators could change the optics as well as the proximity and approach for some tight procedures like intubation. Any guidance on that?
No, we don't. I mean, we know that there are, folks who've used this type of equipment for intubations. One of the things that we have recommended is that people who are considering, providing care for patients, if they have a simulation lab, is to simulate, to practice doing some of these procedures. And if, you haven't, you're anticipating intubation, to have anesthesia folks who practice wearing the face shield. Now, some of them already do have experience wearing that type of equipment for intubations, but practice would be key.
And a second question, are there any known, I guess, index cases outside of Spain, the United States, and then, of course, the red zone, the hot zone in West Africa?
None that I'm aware of.
And how will the CDC, World Health, or CNN let us know when that happens? I'd rather hear it from you guys in a controlled environment.
Probably all of the above.
Yeah. Microphone number 4.
Matt Gold, neurology in Massachusetts, but it's my understanding that the proportion of severity of illness is proportionate to viral load. And my question is, what constitutes the difference between individuals with a greater versus lower viral load? Is it simply the host immune system, which doesn't catch up early, or is it in some way the way they're first infected?
Yeah, that's an excellent question. I don't know the answer to that. I mean, my assumption would be that it probably has some relation to issues related to host immunity, but I don't know the answer to that.
Thank you.
Thank you.
Microphone number 5.
I'm Bill Gilmer, Chief of Staff of a community hospital. My lab is concerned about running routine labs on a suspected case should it come up. Should they be?
Our recommendation is that these samples can be managed safely and effectively. We have an extensive guidance document on how that should be done, the types of protective equipment that should be worn by lab personnel, including the use of a biosafety cabinet or a plexiglass shield that would greatly minimize the risk of any type of exposure. So there is guidance for how these samples can be managed safely, and many of them have.
Number 2.
Okay, Mehta from Oklahoma. Thank you very much. Really enjoyed listening to your presentation. 2 quick questions. We know that the serum from the patients who recovered has been used and is very useful to treat the patients. Has there been any research to isolate those antibodies to see if they can be used in future to treat other patients? The second question is the PPE you showed appears to cover from head to toe, which is the enhanced precautions. Yesterday, we heard that someone saying that that was introduced for the convenience sake, and I would like to see what you think.
I don't know the answer to the first question on convalescent, the serum, the antibody isolation. I didn't hear the second question fully.
The PPE that you showed seems to cover from head to toe.
Correct.
Is that a standard precaution now?
I believe that's the recommendation that most organizations are following. The Doctors Without Borders, MSF, has that as their recommendation. It's the CDC recommendation. WHO recently issued their recommendations, and it's very similar to this.
Number 4.
David Hexter from Maryland. I have a couple of questions regarding your protocols. Number 1, what if the patient presents to a location where you don't have an isolation room, such as a private physician's office? Would you recommend putting them in a room that maybe is not an isolation room, or should they be directed back to their car and we call for help? Second question is, and that's assuming they're, of course, healthy enough to go back and sit in their car.
Right.
Second question is regarding the doffing and the recommendation to use hand sanitizer between each item maybe that's taken off or areas of contamination. I noticed you showed a picture of hand sanitizer with a pump on top. Are you recommending that where it could potentially become a fomite, or should it be an automatic dispenser?
I think the touchless dispensers are preferable. I guess they didn't have clip art of a touchless hand hygiene dispenser, but yes, absolutely, touchless dispensers would be preferable. In terms of the office, if that were to occur, any private room would work. But I think it's case by case, as you've mentioned, a patient who's feeling very well, who just has a fever, it might be advisable not to even bring the person into the clinic, to safely manage them outside the clinic. So I think that's got to be on a case-by-case basis. If they come in, any private room would be the place to put them.
Thank you.
Microphone number 2.
Thank you. Richard Evans, Maine. First, I want to thank you for being here and helping us out. This has been very valuable. I've been on a couple of conference calls over the last couple of weeks in my state, and can you help me understand, is there a definitive time period when the infection is most, I guess, out of control? And the numbers that I've been hearing is between days 8 and 14. If you could comment.
You know, I think that the risk of infectiousness is highest when the patients have the tremendous gastrointestinal symptoms, because that's when the risk of contamination of the environment and the exposure to body fluids is so high. And that the gastrointestinal phase of the illness and the patients who develop it seems to develop sometime around day 5. Okay. So I would say that gastrointestinal phase really is that high-risk window, and it's in that range, that kind of that after day 5 or so, that appears to be really, really risky.
Okay, thank you.
Thank you.
Well, Arjun, thank you very, very much for giving us your time and knowledge and expertise. We are very appreciative of it. And please join me, everyone, in thanking him for his work here. Many folks have left. I am pleased with the number of people that were in attendance, and I think this has been a very valuable experience for everyone. Don't forget to get your CME, and the code is 4